I will talk about the ENT perspective and the role of radiology. We know that dealing with ENT disorders, we deal with breathing, feeding, hearing that is strictly connected to speech, and we will try to highlight what we can get from a clinical perspective and what we learned from radiology over the years. So, breathing is extremely important. We all do that over the course of the day, and it is frequently an urgency while dealing with patients with craniofacial malformation, but these problems may arise during the childhood, and we have to deal with them. Also, feeding is extremely important, and there may be some urgencies while dealing with feeding and swallowing disorders, but also over time other problems may arise. And hearing is crucial for the overall development, neurodevelopment of the child, and is strictly connected to speech and language development. While analyzing a cohort of our patients with craniofacial malformations, we observed that a great part of them, more than half of them, perform a CT before the 5 years old, and most of them before the first year of life. So this is important to remember while dealing with these patients, because radiology is a great and powerful tool, but X-rays, for example, can be impactful in terms of tumor generation and also the eye evolution. So we have to manage it over time and try to get the best out of it. And, for example, we perform imaging when we deal with breathing issues in the first phases of life that may be related to choanal atresia, laryngomalacia, tracheostenosis, that are urgencies in the first phases of life, but during the childhood of the patient, we may have common problems that can be over other systemic problems that are caused by the malformation of the child. So we may have hypertrophic tonsils, hypertrophic adenoids, macroglossia that may impact the breathing of the child. But when you have a breathing problem of a child, it may be not visible only by a clinical evaluation. And this is a great study that was performed by the Erasmus Medical Center, dealing with around 300 between patients and controls, which highlighted that breathing problem may also be related to skull deformities, to tonsillar herniation, carry-1 malformation, syringomyelia, cerebrospinal fluid outflow obstruction. So maybe the patient you are dealing with have a common cause of breathing problems, but sometimes you have to deal with severe problems that need other interventions, for example, maxillofacial or neurosurgical interventions. While dealing with feeding, we observed in a cohort of our patients, around 200 patients, that the parents reported that their child had feeding or suction issues in 20% of them. So this may be underestimated in our clinical evaluation, but for parents it is quite important, this issue during the childhood and the development of him or her. And we can deal with these kind of problems with a clinical bedside evaluation, or also with FEES and endoscopic evaluation that can reveal orodental anomalies, mandibular anomalies, cleft lip and cleft palate, pharyngeal, laryngeal, or esophageal malformations. But we learned over time that a radiological assessment of these patients by means of CT and MRI performed for other issues, that also salivary glands may be involved by abnormalities, mandibular condyle can have strange shapes, and also cranial nerves may be involved. For example, the oculomotor nerve, the trigeminal nerve, the facial nerve, and the vestibular cochlear nerve can be involved. And we will see that these features may be present together, making the overall outcome of these patients worse over time. And concerning hearing loss, we have to remember that hearing loss is a significant cause of speech and language delay and problems during development in terms also of cognitive abilities and educational performance. And while dealing with hearing loss, 50–60% of the causes of congenital hearing loss are hereditary. So, and among them, 1/3 has a syndromic hearing loss. So we have to think about it both ways. When we have a syndromic patient, we should think about the hearing loss as a possible cause of worse result over time. But when we have a patient with hearing loss, we have to check for other clinical issues in the medical history and in other parts of the body. There are 300 causes of syndromic hearing loss, and some of them are well known and are syndromic. For example, Chad syndrome, Waardenburg syndrome, Treacher-Collins, KID, and syndromic craniosynostosis that cover over 180 forms in which the fibroblast growth factor receptor genes are involved, and these genes also have a role in the development of the inner ear. So we have to remember this while dealing with these patients. For example, we have some information about these syndromes, but very few studies are available in literature. So one of the aims of this group and this network may be to further investigate the prevalence of these malformations and the shape, the characteristics of these anomalies. For example, while dealing with patients with Crouzon syndrome, we know that a small part of them has an external ear deformity, but a lot of them have middle ear pathologies, both in terms of congenital abnormalities of the ossicular chain and the middle ear, but others have recurrent types of pathologies, for example, otitis media, perforations, and so on. And even if these causes can be removed with intervention or the development of the child, these patients are fragile in terms of the speech development. So rehabilitate hearing, also the conductive hearing loss, it is extremely important to provide the best possible results in terms of hearing and speech capacities. So we have to remember that some of the causes can be removed by, for example, some tubes within the tympanic membrane, but others are congenital cause, malformative cause that can be treated with surgery or, for example, hearing aids. And also these good article report a significant amount of patients with sensory neural hearing loss, but without specifying the percentage of patients that may have it. So we have gross information about them, and the conclusion of this study is to always check the otological and audiological follow-up over time of these children. Also, for Apert syndrome, we have a variety of inner ear malformations, and the identification is crucial for the overall management of the hearing loss. The malformations typically are observed in the vestibule and the semicircular canal and the cochlea, but also a high-riding jugular bulb can be observed with the potential concomitant presence of the dehiscence of the posterior semicircular canal. So there may be causes of conductive hearing loss or mixed hearing loss in these patients that do not rely with middle ear pathologies, but are caused by the inner ear malformation that cause them. So while dealing with these patients, we can have recurrent episodes of otitis that may cause a conductive hearing loss that should be treated in the first phases of life, but also we have patients with cranial nerves abnormalities, cochlear abnormalities, and vestibular abnormalities that we can see by means of CT or MRI. For example, in a recent study from our center, we observed a cohort of patients with Charge syndrome in which the cochlear nerve was not visible by means of the MRI, but performing the CI, the cochlear implantation in these children, we observed good auditory results. So we have to weigh the role of imaging and try to assess the risk of the procedure and then decide what is the best for the child. Because while dealing with hearing, we have a lot of options in terms of rehabilitations. For example, we have bone conduction, air conduction, hearing aids, cochlear implantation, and brainstem implantation. And while dealing with cochlear malformations, we have a lot of options in our hands. For example, some patients need only an hearing aid, others require a combined approach with a surgery of the stapes, for example, and a hearing aid. Other may require a cochlear implantation. Other should be advised to perform a brainstem implantation. And as you can see in the scheme, the shape of the cochlea may be quite different, and the characterization in terms of imaging of these kind of anomalies is crucial for the overall surgical management of these patients and to assess the risk during the surgery, for example, for Gusher, or for the risk of meningitis of these children that should be advised to have a vaccination as early as possible. And going beyond the hearing involvement, we discovered that in patients with hearing problems, also salivary glands abnormalities and mandibular condyle anomalies can be present, and this can affect feeding, can affect swallowing, and also can affect the articulation of speech, as well as the malformation of the cranial nerves. As we said before, the identification of cochlear anomalies may be related to hearing loss, but anomalies at the vestibular and semicircular district may be related to neurodevelopmental or motor issues during the childhood and over time. Also, the observation of malformation within the brain may be related to cognitive issues, and the abnormalities in the vascular system can be useful to be understood in order to better plan the surgery. And also the malformation in the spine can be an issue while dealing with the intubation of these kind of patients before the surgery.